So we have 30 minutes to discuss whether global CV risk assessment is a science or an art. Who say it's an art? So it should be a science for about 85%. I think it's a science with lots of fudge factor introduced into it. My disclaimer, and I have no conflict of interest. I'll be going along with the SHEP tools, the SHEP recommendation, which has a very valid system. What's my topics for the next 25 minutes? That you would be able to do a critical appraisal of CV risk assessment. Is it ethical to say, as a health practitioner, to tell anybody, I know you're going to die, I know you're going to do this, you're going to have your stroke? Do we have enough accuracy to use this as a tool for communication? And I will show you some indication, many limitations for CV risk assessment. Who knows about vascular age? Who is using vascular age for communication? So, you're in the good session. Lots of things to learn today. Which is wrong. It's lots of things to reassemble, reposition. For those who listen only for the first 3 minutes, this is the big message. As a Quebecer, I'll try to use my UK accent. Where you are on the queue to take the bus is important. When will the bus pass is much more important. So discrimination is on the waiting list, on your patient list, on your clinical day. Among your clientele, which are the most at risk is important. But when I do practice in a GP clinic, when I do practice in my own clinic as a cardiologist taking care of vascular patient, it's much more different. So if we want to have some accuracy in our CV risk stratification, we need a tool with a precision, which we call discrimination. But our tool, which have been developed in other countries most of the time, should be calibrated for our Canadian population. Nobody has the magic formula, okay? Nobody will die at 2.6%. You either die or don't die, stroke or not stroke. What we can tell patients is they are in a 5% group, in a 15% group. That's what we can tell. And many of our formula are short-term, next 5 years, next 10 years. It has no importance when you do assess the risk of somebody age 25 that is going to die at 82 instead of 85. So we have to look, there is no magic formula, and the formula has to be adapted. You've earned this, you've learned this, you earned this. We must adapt to our patient. I'll be using one of the modules which is available in the SHEP is famous because there is a toolbox to disseminate SHEP recommendation. Among one of those toolbox, among the box, there are some modules where you can use. So it's presented to you. She's a nice lady. She comes in for annual medical. She goes aerobic classes. She doesn't smoke, but she puts in 2 or 3 cigarettes a day, and sometimes more. She has no problem. She has chosen quite wisely her parents. Her mother is age 74, possible claudication. His father is still enjoying ski. You do your physical exam. Of course, you've used the BP through, of course. Basically, normal exam except the blood pressure, except BMI for Deborah, okay. Labs are coming in, fasting glucose normal, AB1C normal, lipid with the normal limits of your labs. So I'm happy to speak to you because I'm the bottom line. I'm an inferior doctor. I treat people post-MI, people with angina. You are lucky because you can do superior medicine. You can prevent the disease. So by using CV risk stratification, you may select those. This is our dream, prevent disease. When I do my clinic, it's fairly easily. About 85–90% of my practice is established vascular disease. When you do your clinic, most likely 5 to 10% if you're doing adult. So in an average adult clinic, about 5 to 10% will already have established vascular disease, and this is not the topic of my presentation. 5 to 10% will have diabetes, and when they have a 15-year career as a diabetes patient, when they have at least 2 other risk factors, this is not my presentation, they are high risk. If their BP is 180/10, this is not my presentation. A single markedly elevated risk factor puts you automatically at high risk. So basically, are they established vascular? Are they diabetes fairly long-standing? Do they have single elevated? They are high risk. This not concern my presentation today. What is my presentation is the 80 to 85% attending your clinic, which are a certain age, elevated BP mild, as we say, and are they at risk or not? Because we've learned from the past that if you look at a single risk factor, like cholesterol, on dotted line is the cholesterol of non-vascular patient. The full line is patient with coronary artery disease. You cannot distinguish using cholesterol level. You cannot distinguish using HDL level. It's the same thing with the blood pressure. If, of course, as BP goes up, the risk goes up. When was the last time that you saw somebody with a 200 millimeter systolic blood pressure? Most of the patients we see in our clinic are over here, and therefore, after 5 years, 10 years, this is where the mortality will be, between the 120 to 140. How can we select who we should treat? We must be thankful to Framingham. Framingham was founded in 1950 to find out about the cardiovascular epidemic. It's a study which I enjoy, which I share a lot because, for your knowledge, 50% of the people in the Framingham study are coming from the province of Quebec. We had my ancestors, many of them had to move down on the East Coast to work in the mills, and this is where that study was done. And this is one of those nice Labos and Eastern Township lady who survive in the USA. What is Framingham telling us in 1961? In 1961, Framingham tells us that if you're a woman in yellow or a man in red, you're twice at risk being a red, which is a man. Is that art or science? Okay. Next step. If you're a man in red, and if you have elevated BP, elevated cholesterol, which these days we're over 260, which is close to 6.5 millimole, or if you had the LVH on ECG, your next 6-year incidence rate was 500 as opposed to a woman without a risk. So you can discriminate in your office who is at risk for the next 5 to 10 years. This is called discrimination, and it's another example that cardiovascular disease is multifactorial, and looking at hypertension is wrong. Looking at the patient with hypertension, you'll find lots of elevated cholesterol and so on. Does diet works? I enjoyed this slide because it's a slide done between 1972 and 1992. There was no statin, there was no Mevacol, there was no Lipitor, none of them. What was made was a political decision between Minister of Finance, Minister of Agriculture, and they modify the subsidies for culture. And if you look here, what was the average cholesterol? This is North Carolina. They were famous because they have the highest world rate for coronary artery disease. So just by modifying diet, by doing school program with the kids and so on, it's not a physician in his office, it's a general population approach. You can see the average cholesterol move every 2 years to a mean. And what is important at the end of the day, they cut their death rate by half. So diet works before the drugs, but it's on a population level. Also, in same time, the same part of that study, you can, using Framingham opposite. If I reduce my smoking in my population, what should be my reduction? Expected reduction of coronary disease by decreasing smoking, expected by decreasing blood pressure, by changing the diet. That's the expected global CV risk reduction, and that's the observed. So this is a reverse Framingham. I don't tell you, you have a risk factor, you're going to die. I say, modify the risk factor, and population is doing better. So we need this as a background for what we do in our clinic. Let's go back to Pamela. Most of you, I think, should be using Framingham, and I think it's interesting. As a rule, if you consider cholesterol, BP, and smoking, you can explain about 75% of CHD. If you add in on diabetes, you go up to 85. It's because diabetes is only 5 to 10% prevalence, while smoking used to be 50% and so on. So 4 factor would explain about 85%. So typically you would use some paper given to you by rep or which and so on, and you would put age, there's a table for women, you would put age, you would put HDL. It was poorly translated from USA, so there is no perfect cut over there. Finally, you get up to some points, and another table gives you that for those points, you got these risks. Next 10-year risk. Risk of what? Okay, which 17% risk of what? 13% risk of what? And that's one of the problems with the cholesterol program, is they've been changing their 10-year risk of what? At the beginning, it was being high risk was 30% of total CHD, which is death from CHD, MI, unstable angina, and chest pain. As a matter of fact, in women, 50% of the outcome was chest pain. Would you treat people for preventing the next 10-year occurrence of chest pain? So lots of complaint. So they move on to hard CHD, which is death and MI. But in today's research, CHD is about only 50% of the cardiovascular outcome. Stroke, cerebrovascular is another 50%. So you needed to include a risk assessment for CHD and also for cerebrovascular disease. So they came up with a global CVD, and they maintained the same 20%, which means that they're counting more, but they maintain the same level, which is it's kind of the lower by 100% their definition. At the opposite, all the European countries are now using a system called SCORE, which is the Systemic Cerebrovascular and Coronary Heart Evaluation, and a group of us have calibrated the score for Canada. And it's a 10-year risk of CVD mortality, cerebrovascular and coronary. And like we're used to, we use the traffic system, low risk, below 1%, high risk, over 5%. Very, very complicated. Men, a woman or man, non-smoker or smoker, divided in age group, divided on different level of BP and different level of ratio of total cholesterol on HDL. And this color scheme has been decided because for communication purpose. So